turn things over to today's speaker, Nikisha Watley-Leone.
Thank you, Keely. So today what we're going to be discussing are going to be about ways to challenge and address behavioral health stigma in a healthcare setting. And what I hope to be able to convey to you guys are ways to deal with some resistance that may occur or pop up when you're trying to integrate behavioral health services into your areas. At the end of the presentation, then of course we'll have opportunities for questions and answers. So I thought it would be good to start out with just, identifying the elephant in the room. And as we go through this presentation today, then I hope that you will be mindful of just taking your own notes around what may be your own elephants or what may be your department elephants that may be sitting on the couch. As we go through these first initial slides, and I wanted to make sure that everyone had a good foundation of what behavioral health, mental health, and substance use is, because a lot of times we use these terms throughout the field, but then we don't always exactly understand what the difference between them. So behavioral health is more of a way of being more inclusive. It includes not only the ways of promoting well-being by preventing or intervening in mental illnesses such as depression or anxiety, but also as an aim preventing or intervening in substance use and other addictions. So we think that behavioral health is a way to basically identify emotional health in a less stigmatizing manner than mental health as a discipline as a whole. So we use it as a blanket term. Mental health, of course, is a person's condition with regards to their psychological and emotional well-being. And, Wikipedia obviously defines it as a level of psychological well-being or absence of mental illness. And we know that 1 in 5 Americans experience a mental illness or substance use disorder each year, and the majority also has a comorbid physical health condition. And what is substance use? Substance use disorders, also known as substance abuse, disorders occur when the recurrent use of alcohol and or drugs causes clinical and functionality significant impairments such as health problems, disability, and a failure to meet major responsibilities, whether it be work, school, or home. So I want you to remember that when we discuss substance use or addiction, then that also is under the behavioral health umbrella. So there's a clear connection. We used to treat it separately, but now we realize that substance use, is very co-occurring with mental health, and that there has to be, or in most cases, there's an underlying mental health concern there. So and here you see where it says there's a definite connection between mental illness and substance use. And a lot of times we see where people are self-medicating just to escape the mental illness in order to cope. And in our field, we call it a dual diagnosis, but it's the same as co-occurring disorders. Sorry. So stigma. We know that it's a mark of shame, disgrace, or disapproval that results in discrimination. And as it relates to mental health stigma, then it's an attempt to label the mentally ill people as being less worthy of respect than others. Stigma occurs as a result of stereotypes and negative perceptions that's often associated with mental health conditions. It can occur socially and also as a self-stigma, so externally or internally. And it's a major barrier that prevents individuals from seeking help for what is often very treatable. And so these two types of stigma we'll discuss shortly, but I want you to be aware that, I think that we've done such a poor job as a society that we have externalized the stigma in a way that it's become the norm. And then by way of that, then it's easier to accept it internally as well. So the external stigma, aka social stigma, may be obvious and direct. For example, when someone makes a negative remark about another person's issue or treatment, or it may be subtle, such as when someone assumes that a person is unstable, violent, dangerous because of his or her mental health condition. I always tell people that it's not the patients that come into our clinic to get assistance, but that we need to be worried about, but it's the ones that need to come in to the clinic for assistance that we need to be most concerned with. So examples of social stigma is that people with mental illnesses are dangerous, unpredictable, attention-seeking, having self-inflicted problems, or that they can just think their way out of it. I'm sure we've heard this a lot. Self-stigma, it exists when people with mental illness internalize the negative stereotypes and opinions towards themselves. These negative perceptions can lead to self-blame and low self-esteem. Individuals with a mental health issue often say that stigma is far worse than the illness itself, and that's pretty big. 69% of people with psychological distress will hide it from their coworkers. It becomes a barrier to seeking help, obviously, and they suffer in silence. Decreased self-esteem, decreased self-efficacy, and less likely to reach their vocational goals. And then, of course, it decreases the quality of life. So all of that self-stigma leads to the silence, but the underlining is the fear and the shame that reinforces it. And so that leads to the isolation or untreated disease, deteriorating physical health, because we know that with the comorbidity amongst mental health and physical health, if you don't treat the secondary if you don't treat the secondary condition, which could be the mental health disorder, then it's going to impact the patients reaching their primary goals that's related to the physical health. So we know that it will worsen the disease. Social versus self-stigma. So basically, the social stigma is the public's negative perception of and discrimination against the mentally ill, and then the self-stigma is the acceptance by those with a mental illness of prejudiced perceptions held by others. What we do know now is that studies have shown that one of the central obstacles is the negative stigma attached to mental illness by society at large, which is much more powerful than the labels attached to people with other disabilities. This stigma may lead to social exclusion. A lot of times we're here in the healthcare arena how we just don't want to label a patient, or we just don't want to give a patient a mental health diagnosis and what that can do to their quote-unquote record. But I'm here to tell you that the behavioral health records are far more protected than any other medical records could be. They have an added level of confidentiality, and so that's another myth that just reinforces that stigma of behavioral health being treated differently. These are all words that we've all either used or have heard as we describe people that may be different than ourselves or could be similar to ourselves. And it says, sticks and stones may break my bones, but words will also hurt me. This is a campaign that was called Stamp Out the Stigma in the UK. So we know that there's repercussions feared by the mentally ill, and these are some examples of those. Limited career advancement opportunities, employment discrimination is huge, exclusion from social circles, obviously, loss of spouse and partner, judgment from the religious community even, and health and life insurance limitations. Well, we know that for sure. We know that 78% of adults with mental illness and 89% without believe that treatment is an effective method to help patients lead healthy and normal lives. And then 57% of all adults surveyed felt that individuals are compassionate and sympathetic to those with mental illness. 25% of those adults with mental illness believe that to be true also. Just some stats for you. Stigma embraces both prejudice attitudes and discriminating behaviors towards individuals with behavioral health problems. Who holds these beliefs of the mentally ill? Everybody. Family members, friends, teachers, us as healthcare workers, co-workers, the government, when you look at the Medicaid and Medicare laws, and also health insurance companies. The effects of it is huge. On average, mentally ill people will wait 10 years to seek treatment after the symptoms first appeared. And this is due to the self-stigma, also the inability to find help. So access to care is a big one, of course. And then nearly 2/3 of all people with mental illness do not seek treatment. That's pretty big. The society burdens are as follows. Disability is one, homelessness, substance use, crime, and death. And then if we take depression and we say, let's look at that as one illness that's very prevalent amongst society. the leading cause of disability in the United States for ages 15 to 44, and the leading cause of disability worldwide. So ranked amongst the top 3 workplace issues. So this is huge. So a lot of times we'll hear people say, well, no, we don't have that problem here, or we don't know anybody. Well, I'm not sure where you're working or where you're living, because those numbers speak for themselves. And if you look at the economic impact of just depression alone, $70 billion annual toll on the U.S. businesses, and $12 billion in lost work days each year, $11 billion in other costs, which includes decreased productivity. When you look at addiction and mental illnesses, compared to controls, people with severe mental illnesses are 4 times more likely to be heavy alcohol users, 3.5 times more likely to use marijuana, and 4.6 times more likely to use other drugs, 5.1 times more likely to be daily smokers. So substance use and mental illness, just remember, is hand in hand. And we've all been hit in the face with suicide. It's in the media, it's everywhere. We can't get away from it, and the numbers are continuing to climb. 30,000 reported suicides in the U.S. each year. And we often get a lot of calls. I lead a department or service line throughout a hospital system in Atlanta, and I'm often called upon to bring in people to just speak on what to do with suicidal staff members and also suicidal patients. And, I mean, these numbers speak for itself, but, consider yourself lucky if you haven't had to deal with a patient that's been suicidal, or a family member, or a friend, or a colleague, because the numbers are just continuing to increase. And it's sad, but it's true that it's just kind of become like a go-to method to dealing and coping with mental illness, and just issues, period. So it's the 4th leading cause of death in the United States for ages 18 to 65, the 3rd leading cause of death for 15 to 24, and the 4th leading cause for 10 to 14. It continues to get younger and younger. 2/3 of suicide in the U.S. are due to depression, which is treatable. So what does stigma look like or sound like in the workplace? So you take all of that information I've just given you around depression and substance use, and if you look at the stats, and we know that we have people that are dealing with these situations, whether they're dealing with them in silence, or if they just can't help but let it leaks out eventually. I always tell people you have to be really careful about what you say and who you say it to, because you never know what someone goes home to, what they grew up around, or what they're dealing with themselves. And so what that can tend to look like or sound like in the workplace when you're dealing with stigma is just that behavioral health issues are just not discussed at all. And when behavioral health issues are brought up, then they're easily dismissed. Behavioral health issues can be viewed as not our problem, quote unquote. And the unspoken belief is that we don't discuss those types of issues while at work. Commonly used quotes: I don't think that they're that bad to get behavioral health involved. A lot of times we'll hear nurses or physicians to say that about their patients. And then another is they're just an addict. One thing that we've had to deal with a lot are addicted mothers, and some of the staff members will get really upset and take it personal when they see a baby being born addicted. And then another is he's crazy. We've all heard that and have used that and continue to use that. And then another quote is, we don't have any place for these people to go, because we know that they clog up the emergency room and patient flow gets impacted because of the lack of psych beds. Questions that you can begin to explore as you're taking your own, assessment of where you guys are in this process. Do you have a referral process for behavioral health needs? Do you know how to introduce behavioral health services if you had to? Are you comfortable with making a behavioral health referral? Do you have adequate behavioral health services in your area that are readily available? And if a mental health emergency occurred, do you know what help is available to you? And if a colleague appeared to be struggling emotionally, do you know what you would do or what to do? And when we have a patient that's suicidal, do you feel equipped to care for the patient? We've been up against that for the past few years, where we will have patients that will present in a psych emergency, excuse me, and everyone would kind of just get really anxious anxious, and our anxiety would be higher than the patient's anxiety. And it was all because we didn't have a clear picture of what to do when it occurred. And so I always say, we don't need to be more anxious than the patient. We need to know what our process is before the incident presents itself. And so I think that that's a huge way of feeling equipped, and it helps also with the staff being able to address and not overlook issues, because they know if they ask a question or assess or pick up on a need, then they know exactly how to get the patient's needs met or the colleague's needs met. So what are some signs of stigma in the healthcare setting? Well, it's never talked about, obviously. Patients aren't screened or referred for behavioral health services. Something that we've been working on is we had to create a more streamlined process where all patients are screened for suicide and all patients are being screened for depression in some settings. And then we have distress screenings in our oncology settings. And about, some of this came about because of different standards that are expected. But it has also helped us to educate staff and decrease stigma along the way. And we've realized that some of the stigma has stemmed from just clear anxiety and fear and ignorance around what it looks like, what it feels like from a mental health standpoint, and that it's not always what you think it is, and it doesn't always look how you think it looks. And so we've made a lot of headway in this area. And it takes out some of that subjectivity of people just assuming that they can look at someone and know whether or not they're doing good, quote unquote. Another is proper attention and programming just hasn't caught up with the patient care demands. So that's a clear indication that there's a stigma somewhere in the organization that's blocking some of that program development. Lack of staffing for behavioral health care needs, and access to care is limited in comparison to other specialties. That's a national issue. Funding has been one of the primary reasons for that. Behavioral health isn't recognized within the organization such as other illnesses, and we all know about that. What causes this? Ignoring the fact that it exists. And we can no longer ignore it because we just can't, and numbers won't allow us to. There's no discussion, and there's a lack of acknowledgement, lack of leadership support. I think one of the biggest things is that you have to get administration to be in support of integrating these services. And I know that behavioral health sometimes can be a financial burden for many organizations, but what we've learned is that if you don't treat it, then it's going to continue to, you don't have to necessarily have an inpatient psych facility on site, but you need to have a way of connecting patients to get the interventions that they need, or it's going to continue to be a revolving door. And so you have your readmissions and things of that sort that play into, the untreated behavioral health concerns, where the patients are coming back to the ED multiple times because they're not getting their needs met and they're not sure what's going on. So we know that although behavioral health may not make you money, but it will save you money, and saving money is making money. And so that's something that can be, I think when you're trying to get leadership support, that's a big key factor in being able to get some support there, and also the risk that's involved in not treating the mental health care component of patients. So the other is mental health can be given a low priority in relation to other medical fields. Stigma is related to insurance and billing and reimbursement rates not even being as high as other areas. And it's also associated to labeling a person, quote unquote. How does this impact patient care? Well, it clearly becomes a barrier to care. Our issues sometimes become the patient's issues when it shouldn't. I had a nurse once say when she was doing a distress screening that she didn't feel like the patient needed to be presented with a distress screening because they had a lot on their plate. Well, needless to say, the patient was already seeing a psychiatrist and a psychologist in the community and was just waiting on us to screen them to see how and if we wanted to integrate and coordinate care with the outside providers. So sometimes our own issues leak onto the patient's issues or other people when we're not even aware of it. We've even had issues where nurses would, not issues, but we've had a situation where a nurse was so uncomfortable with presenting a screening to a patient that she filled it out herself. And it was because she just didn't feel equipped enough to be able to introduce the screening to the patient. So these are all education points that I think feed into the stigma that impacts patient care. And so when you're creating your own series of education, I think it's really key to understand what the resistance is from staff and what's reinforcing some of that fear-based behaviors, some of those fear-based behaviors. Okay, so back to my list. Proper care can be delayed and are missed, obviously, and it can also cause misdiagnosis or overdiagnosis. Reinforces a culture of mistrust, of course. So if I see how we're treating patients that may have an emotional health concern, then why am I going to feel comfortable coming to my boss or supervisor around something personal that may be going on with myself? And so if we know, going back to the stats earlier in the presentation, if we know how prevalent depression is, then is it likely that one of your staff members will come and confide in you about what's really going on when you see that their performance is going down? These are all things that we need to take into account and think about. The other is that it impacts the quality of care provided. Why should a patient come to your hospital or your clinic when the care is split and versus going to a cutting-edge hospital that already is offering integrated care and wellness? And so I think that those are some things that if you want to, stay ahead of the curve and stay competitive in the healthcare market, you want to definitely figure out ways to integrate the behavioral health component so that we are treating the whole person. It reinforces the ignorance associated to mental health as it not being equally as important as physical health. And, you're just not treating the whole person when it's impacting the patient care. Here's something. We would never say it's just cancer, get over it. Again, how does it impact the team and the department? It can impact cohesiveness, of course, and it can cause colleagues to feel uncomfortable speaking up or sharing their own experiences with such illnesses. It keeps stigma going. It can also be viewed as being discriminatory or prejudiced towards mentally ill. What if an employee goes home to a mentally ill family member? It could impact retention. We know that, if you have a mentally ill family member, sometimes it takes for you to take leave off of work if you don't feel that you're protected or that you don't have the support in place to understand, excuse me, to understand exactly what's going on. So you have family members that have to take FMLA or short-term disability to take care of their family members that are impacted. It could also impact connectivity amongst the team, and it could impact the safety in the workplace. What is my responsibility in this, and how can we eliminate the stigma? Well, we can create a space where behavioral health concerns are discussed equally, such as other healthcare issues. Something that we did is we heard from the staff, and they would say, they would feel burnout emotionally or have compassion fatigue. So then you create a space where maybe instead of going to the break room for lunch, then you have a meditation room or a quiet space where people can just go in and have a breather for 30 minutes or an hour, however long they have for lunch. And so I think when you start creating a space where it's symbolic to health and wellness, then that lets your staff members and your team members know that, hey, we're taking wellness serious. It may not just be mental health, but just wellness as a whole. And that helps to decrease the stigma. And then it also prepares and lets the staff be better equipped to be able to deal with some of the patient care issues that are becoming more and more complex in today's society. So you want to incorporate it into your daily practice and bring in specialists to educate the staff. A lot of people don't know the difference between a psychiatrist, a psychologist, a psychotherapist, a counselor, even a spiritual leader, and a social worker, a caseworker. We have all these different disciplines in our field, and I think that it's important as we're trying to decrease the stigma that we know what each scope of practice for each person does, so that even when you're referring patients or employees or whoever to these specialties, that you know what you're referring them for. So I think that that's a big learning curve for many. Support those that require additional support, and words do matter. So watching what we say and how we say it. So some low-hanging fruit, something that, I created over the past 3 to 5 years is that my task was to take on behavioral health and integrate it into a general med setting, into different service lines. And where we are now is that we have set the standard and the expectation of how, even though we don't have an inpatient behavioral health unit, but if a patient shows up and they have some emotional health concern, then it's very clear on what the expectation is of how they will be cared for emotionally. And so when I started this campaign, then a way for me to integrate and penetrate the system was to figure out how can we recognize mental health issues. And Mental Health Awareness Month is each May, and so we used that to kind of spark off discussions and get people to know that we existed. It was interesting that, within a huge organization that I'm part of, no one seemed to know that behavioral health still existed, that we even had the departments, the consult teams, and outpatient care. And so as we start digging deeper, a lot of it would just stem from providers not feeling comfortable making the referrals. So a lot of stigma-based type of behaviors had reinforced just not knowing that we even existed. So what I would do is I would use Mental Health Awareness Month, and I still do, and we do a lot of different fun activities and go and integrate it within other departments and have people to participate. And so that's a big one. We started a campaign to assist with increasing awareness, and it totally has shifted the culture. It took some time, but we're there, and we set the expectation around how we wanted patients to be seen when we identify that there's a need and who those patients would go to. And so we made it really fun, and you can too, and we designated a behavioral health, or when we went to the floors on the general med setting, we had behavioral health champions. And so these are our behavioral health stars that like to take the lead if behavioral health specialists are not available. And so we just built on their interest, and that's something that you can do as well. We created a behavioral health interdisciplinary committee, and we meet and discuss what types of good things are happening and what are some areas of opportunity. And something that you can do that's low-hanging fruit is host events to help raise awareness of mental health stigma, and that has the detriment effect that it has on the mental health sector. So these are some things that have helped us, and that has worked. We created committees, subcommittees, and even have behavioral health task force with different specialty departments. One big thing that I've been able to do is create a behavioral health task force with the oncology department. We have distress screenings in all of our cancer centers, and it's like, I think, 38 cancer centers throughout the state of Georgia. And with that, it came with a lot of stigma and resistance. We have a rural model and an urban model, and so everybody's issues look differently. And so what helped us is coming to the table on these committees and having key components there to represent everyone, so that we can make sure that we're talking through processes and being flexible with how to work through these things. We streamlined and mandated behavioral health-related screenings. This has been really key because it sends the message to the staff and the patients that we are here to help you from a whole health standpoint, and that we want, even though we may not offer inpatient psych, but we can get you to where you need to be if that's needed, or we can definitely get you to an outpatient home base because we have our own services. So we've done distress screenings, depression screenings such as the PHQ-2 and the PHQ-9, and suicide screenings such as the Columbia. And then we surveyed the staff on an ongoing basis to ensure patient and staff safety. This is something that is just not a one-time gig. It's something that you have to keep up with. And what we've been able to do is to identify what are some areas that reinforce the staff to feel incompetent, or what are some areas for improvement where we need to hone in on to make the environment feel more safe for when a patient shows up and they have some behavioral issues. A lot has come out of these surveys, and we continue to do them, and they're anonymous. They're anonymous, and the staff can do them online. And and we've done gap analysis regarding behavioral health care and used that to assist with any of our QI and PI performance improvement strategies each year. I also developed the 1013-2013 committee. So in the state of Georgia, that is our involuntary commitment. And so we had to streamline that process and make sure everyone had the forms and we knew who could do it and who could not do it. But it was a clear or a big education point for staff to know that just because a patient identifies with behavioral health concerns does not mean that they are going to kill themselves or others. But when it does present, we need to know how to deal with those situations. So on this committee, we meet, now we're at once a quarter, but we used to meet once a month, and we would talk about elopements or possible elopements and ligature risks and different types of things that the Joint Commission and everyone else is asking us to do. So that's been really key, and it's not just behavioral health disciplines, it's all the department heads and even some staff members that are just very involved. We have security in there. Pretty much everybody is on that committee. So it gives everyone a place to be able to represent their discipline and come up with process improvement. You can work with the community partners such as the police department, state-funded behavioral health programs, mobile crisis teams, and spiritual leaders, of course. Those are things that have helped us. More things that we've worked on, having a physician champion was really key and continues to be key because a lot of times you need physician to physician to provide education around what it is that behavioral health patients need. So if you can find a psychiatrist that's willing to be that champion for you, that helps tremendously because we know that, psychiatry is a specialized component and you need to get patients seen by that type of specialist, but it also takes for a psychiatrist to speak the medical terms and speak the language from physician to physician so that they can understand what needs to occur in order to get patients seen properly. And then, of course, I mentioned the Behavioral Health Champion Program. So that's something that we've identified these behavioral health champions, and they go out and they're on the floors and they're available to help with some of the ongoing issues that come up. They're not working outside of their scope of practice, but they're there to help train their colleagues like the nurses and the patient care techs of what to do should they forget of how to deal with certain unique situations. And it may not require a full behavioral health consult, but just someone there that's educated in the realm of behavioral health care. Because what this does is allows everyone to be able to carry the weight of where we are with behavioral health care needs. And obviously it helps to decrease the stigma. And then offer mental health symposiums. We've had those and we continue to have those. We've partnered with the emergency room and the emergency department, and we have behavioral health days, 2-day symposiums with them. But then we also have it in med-surg and patient care areas as well. And so this has been very, very helpful. Nursing education series to assist with screenings, verbiage, and how to approach some of these situations. This has been key and it's an ongoing thing. I don't think you'll ever stop needing education. So this is where you want to bring in behavioral health specialists to help equip the nurses on how to talk to patients, how to de-escalate situations, how to counter your own stigma as it comes up in real time. And then we have system-wide competencies on behavioral health, high-risk patient populations. And so that's something that is required on an annual basis. And sometimes some of those competencies depend on the area, maybe twice a year, but definitely with new employees and ongoing. And providing bedside training to assist with behavioral health care is key. Having a seamless outpatient behavioral health referral process and a seamless involuntary commitment process so that, like I said earlier in the presentation, that you know what to do when these things come up and you're not scrambling around and uncomfortable. You may be uncomfortable, but you can diminish some of that by knowing exactly what your process and protocol is. Work with the quality department to assist with quality metrics. What we know about behavioral health is that we live in the gray in behavioral health, and sometimes it needs to be black and white, and we need help with that. And in the quality department or your QI department is the area where I would tap into to help make some of these areas be measured of how you're making a difference. And that in itself can help with getting leadership or administration support on how to integrate more behavioral health type of services in your organization. And of course, you're always welcome to attend Psychiatric and Psychological Association conferences, the APA conferences. That helps a lot with just educating and bringing back materials to your staff on where we are as a field and a discipline and what we expect to see going forward. What can you work on doing in the future to help breaking the cycle? Remember to check yourself. Keep yourself in check. Are you perpetuating stigma? And do a survey amongst your team regarding behavioral health to access your team needs. Guard your words. Language matters. I cannot say that enough. Are you using sensational or fear-based language? People are listening. This says, I suffer in silence. I have a mental illness, but you never know it. And we have the right to end the stigma. And it says here, some people say, I love, I laugh, I have hopes and dreams. I bleed just like you. I am talented, and I'm kind and caring. But you never know if they're suffering in silence. So some tips for avoiding stigmatizing language. They have a language audit that people use, and it's basically performing the audit of existing materials for language that may be stigmatizing, then replacing it with more inclusive language. And then you can critically reflect on the types of information you choose to disseminate to ensure that you're doing so responsibly, of course. And every time you develop a prevention message, consider it as an opportunity to dispel myths and convey respect. This is key. Mental health disorders are not adjectives. A lot of times we'll hear people say things like this: you look so anorexic. Hopefully nobody would say that. But my OCD is coming out again. I swear I'm like retarded. Oh my God. And then another is, my mom yelled at me yesterday. She's so bipolar. We hear that a lot. Everybody's bipolar nowadays. And then the other is, I stayed up until 1 a.m. My insomnia is so bad. Oh yeah, yesterday I'm feeling really depressed. I was feeling really depressed. So mental health disorders are not adjectives. What can I do as an employer? You can educate and inform, communicate about mental illness across the whole organization to reduce fear, stigma, and discrimination. Foster a healthy workplace environment. Establish a culture that is conducive to supporting employees' mental health by raising awareness in the workplace. Programs and your policies should promote that as well. And remember, when you're doing this, just remember to promote mental, physical health, and wellness. All of that is together as an integrated care approach. Strengthen people leadership skills. Train managers how to identify the signs and symptoms of mental distress, and have available employee tools and support. We also see in our outpatient areas medical doctors from our system. We see a lot of medical staff and colleagues and their families, simply because I think we've done such a great job with our campaign and introducing how we expect patients to be treated from a behavioral health standpoint, that the staff only feel comfortable with having their own needs met in our setting. So we feel like we've done a great job with stumping out the stigma. And then, of course, start at the top. Encourage your senior executives to demonstrate leadership around mental health and promote accessibility. Everyone should have an EAP program and other ways to have appropriate referral resources to assist your employees. But if you don't, then I would be shocked. But you definitely want to know what's the route to get EAP involved when you have issues or when there's an identified issue amongst your staff. And how to challenge the stigma. Dispel ignorance by talking and sharing and collaborating and educating. Everything that we've been discussing thus far. Things to remember. Learn and share the facts about the mental health and illness. Get to know people with personal experiences of mental illnesses. Speak up and protest when people, family, and colleagues or the media display false beliefs and negative stereotypes. And create a culture that's one of non-judgment. We can offer the same support to people when they're physically or mentally unwell. And don't label or judge people with a mental illness. Treat them with respect and dignity as you would anyone else. Try not to discriminate when it comes to participation, housing, and employment. Well, we know we have a long way to go with that, but we're getting there. And as a recap, make sure you know the facts. Once you know the facts, then you can speak to it. Watch your words. Challenge misconceptions. Don't be afraid. Report the stigma. And bring in speakers to dispel myths. Educate, educate, educate. Have a seamless process for behavioral health referrals. Become aware of your behavioral health resources and share them with everyone. And guess what? You can't have physical health without mental health. Breaking the silence helps everyone. We all have a moral responsibility here, so hopefully you'll get started. People like you can speak up and speak out. Thank you.
Thank you,
Any
Nikisha.
questions? Sure.
Does anyone have any questions? You may type in the chat box or press *2 to unmute your line.
Hey, this is Rhonda. Nikisha, can you hear me?
Yes.
Okay, good. So one of the things that I know that you feel very passionate about is addressing kind of those inappropriate comments in the workplace when people say something about someone who has a mental illness. And so I'm just wondering, I'm kind of putting you on the spot here, but I know that sometimes addressing employees or staff can be sensitive. And I'm just wondering, do you have any good suggestions or phrases or ways that you would suggest other people do that? Because my guess is that some of the folks on the call today, they hear a lot of those same stereotypes and comments that you had mentioned earlier. So just wondering how you address it when you hear it in the work setting.
Sure. So one example of how we've addressed it is, we've had where a patient would present a certain way, and we've heard where a physician made a comment about the patient, and we used it as a case presentation and scenario. And so we didn't name names, of course, but we used it as how things ended up being really well at the end. So then you can always use it as a case example. But then the other piece of it is I like to come back to the staff member and say, the patient that we saw the other day, and this is what happened. Well, that patient had been dealing with X, Y, and Z. So use it to do like curbside education, but in a non-threatening way, of course. And then they know what they said about the patient. And so sometimes you don't have to directly say, what you said, that was wrong. But when you present it to them in a way and introduce what all is going on with that patient, then it helps them to be able to say, oh, okay, maybe I jumped the gun there, or I shouldn't have said that. Then if that doesn't work, then sometimes you just have to have those direct conversations around, maybe I didn't feel uncomfortable, but somebody else could have felt. Or maybe I did feel uncomfortable when you said this and that to the person. But then the other piece of it, Rhonda, is that each May we use a different theme with the Mental Health Awareness Month. And so, we'll use a hashtag because everybody's into hashtags with social media. So some of those hashtags can be tied to what message you want to put out throughout your system, too. So I hope that answers your question.
It does. And also I'm thinking about something else that you have mentioned in this presentation is just the reminder that, sometimes people might say something about a patient, and again, forgetting that our coworkers are sometimes dealing with these very same issues, either personally for themselves, maybe having one of those diagnoses, or dealing with it with a family member. So that, I guess that would be another approach, just to remind that staff member that it's not just the patients, it's also their coworkers. You just never know what people are dealing with.
You never know, and the thing about it is that we forget that easily. We can easily jump on one side of the fence and talk about the other people, but you have to be careful what you're saying and who you're saying it to. It's so offensive. And I've used that. I would just say it very plainly and direct to in a staff meeting or anywhere, and I'll just say, you never know what's going on in someone's life, so we need to be mindful of this. And ethically, we have a duty to be more responsible with our language.
Yep, good point. Also, I see, Nikisha, that Jen had put in the chat box. She was wondering if you could share the posters or where you got them.
Sure, I can pull that, and I will definitely let you know.
Okay. If you send it to Keely, then she can forward it out to the other folks, or specifically to Jen, but send it out too. Thank you.
Sure.
Any other questions for Nikisha? Star 2 to unmute your line.
Hi, this is Cassandra Beardsley from Wilderness Health, and I just want to thank you. This was a great presentation. I joined a few minutes late, but it was really engaging, and thanks so much for sharing the information.
Sure, thank you.
A question for you. You talked about having an interdisciplinary committee at the employer level, and I'm wondering if you have any best practices or success stories about how you got that going and how you were able to identify, engage folks to help you with that.
Sure. So, so what I started out with is reaching out to the directors and just saying, do you have someone that would be of interest to be part of this committee? And what I would always do is back it up with what the new requirements are per Joint Commission or any type of accreditation body. Because then it's not that you're just doing it because it's a hobby or an interest, but it's something that we have to do to stay compliant, right? And so I would do that, and then they would either be part of it themselves or they would get another leader. And then from that, when you get your core objectives of what you guys want to address, then we would branch off and create a subcommittee. And then that's where we would get volunteers from the ground level employees to be part of the subcommittee. And the way that we would advertise that was through our quality patient safety forum that we have, and also in the different department staff meetings. They would basically do like a commercial and they would recruit people. And so, and then what started happening is that staff members would identify wanting to be more involved in behavioral health care, and they would become some of their goals, their performance goals each year. And so it just kind of just made a total shift where we would get and still we get a lot of people that are so interested in behavioral health care that we have to pump the brakes almost. It's sad. But we're like, okay, let's start here, and then we'll come back around and get more people. But so some of the best practices, I think, with forming your committees is when you have incidents that occur, then you see who was at the table when we had to deal with, say, a disgruntled patient or aggressive patient. So those people that get called to the table, whether it be security, the sitters, or whoever, then that's where you form those are the disciplines that need to be part of that committee. Does that make sense?
It does. Thank you.
And we have we use a lot of incident reports, and so a lot of our best practices have come out of just going through case reviews of different incident reports that have been made. And it doesn't always have to be like something that bad happened, but almost like a close call here. So what do we need to look at? And so out of those projects, then we've been able to form different task force and different subcommittees and committees. And then sometimes, you'll outgrow the committee or you get everything done, then you move on to another area.
And Nikisha, something else that you mentioned that I think is a great opportunity for the hospitals on this call, just knowing that sometimes the rural hospitals don't have a lot of resources as far as some of the providers, but one of the things that I know that you rolled out, which was very impactful, is getting the champions, especially on some of the med-surg units where they were having to deal with a lot of behavioral health issues. But getting folks who had an interest, nurses or techs, who could be trained to be those champions and could be kind of a go-to person for other folks on that unit when they were dealing with different issues. Or then that person could also be a liaison with any kind of behavioral health committee that you have. But also it's a great way to really let staff begin to take more responsibility to keep the right kind of environment for our patients and to make sure that we're watching out for the needs of those patients. But then a developmental opportunity where folks get to kind of be the specialist in an area. So anyway, I just think that's a great way to leverage the staff so that it's not always the hospital social workers or clinicians that are having to do everything.
No, I agree. And another way that, to your point, another area when we were asking for so much help because of the demand, in the EDs, we have behavioral health techs, but we use them as patient care techs as well. And so then from a revenue standpoint, you're able to say, because a lot of times finance will say, what are you going to do with the downtime? Well, when we have a downtime, then you can utilize those behavioral health techs for patient care techs. So that may be a way to get more help too. And you have a lot of people that go to school and they'll just stop with like a associate's or bachelor's level degree with in social work or psychology, but they can't really use it in the field. And so those are the type of people that you want to hire for your patient care techs or behavioral health techs. And then if you don't, in like what Rhonda is saying, what we did on the floors with the Behavioral Health Champion program is that the nurses and the techs will say they had an interest, but they just didn't know what to do. And we formed these education series around whatever topics that they were bringing to the table. And we made it very, easy and fun and interactive, and we used a lot of role plays. So when you use a lot of role plays, then people can retain the information because it's real life. And so then they're not just like, oh, my God, what did they say we need to do? Well, you know what to do because you acted it out. And so that's been really helpful for us.
Any other questions for Nikisha?
This has been really good, Nikisha. I really appreciate you putting this together and talking with us and sharing some of the things that are working for you.
Sure. Thank you for having me. I appreciate it.
Yes, thank you